Multidisciplinary approach and its challenges. That is what I'm going to address because I'm in a maybe second tier city where we are caring for children with spinal muscular atrophy, and it is nothing like an ideal setup which is dedicated to care for SMA. So we work towards achieving these goals. Most important thing which is possible, which I can assure, is about prevention. This is definitely in our hands. It is very much possible when you come to us in a right time. So genetics part, prevention aspect, we have full control because we can identify the gene, we can predict recurrence risk, we can do prenatal testing, we can avoid a baby being born with genetic disorder, in your case SMA, very much. It is in our hands. We can promise you that 100% is possible. But again, coming to the treatment of baby being born, baby is born, okay, you are going to prevent the second baby, but the baby is here with me, what I am going to do. So first thing is, Dr. Vinitha was there, physiotherapy, the rehabilitation plays a crucial role. We know it is a progressive disease. The first thing comes into our mind is the muscles are losing their strength. And again, they are going in for contractures. These are two important things we have to keep in mind. So one is positional issue, another one is strength of the muscles. So to make sure the muscle strength is maintained at least for a little more period of time, we are dependent on rehabilitation consultants. And again, the care is not uniform. We don't have a standard of practice protocols everywhere. It depends on the physiotherapist, the rehabilitation consultant, the centers also. And not everybody is completely experienced to handle children with SMA. We have to accept these facts. These are the challenges we face because I can refer a child to a physiotherapist, but the care, the rehabilitation consultant also, a rehabilitation unit, but the center will be seeing so many other patients, and one of which is spinal muscular atrophy, and their experience towards spinal muscular atrophy will be very, very less than Dr. Vinitha or somebody who's associated with Dr. Ann. So that is the basic challenge. Uniformity of physical medicine rehabilitation, that is a challenge. So uniformity of care, uniformity of advice. So not coming in, but anyhow I'm touching on this. So next thing is orthopedic management. Orthopedic management is more of a physician management than a surgeon, because if you are going in for a surgical management, it means that physically, medically, we've crossed that period. We should have prevented the child going in for a surgery. We should try and prevent. So that Dr. Ann will be touching upon. And respiratory and pulmonary care, starting from vaccinations to proper assessment of pulmonary functions, proper assessment of sleep pattern, all these matters, this has to be continued 6 months once at least if the child is non-ambulant, because this is the major cause of mortality in children with spinal muscular atrophy. So swallowing has to be made sure, sleep and the breathing pattern during sleep, and recurrent respiratory infections can pull the baby's lung volume down. So this care, all these are the small things which can improve the quality of life. Next is nutrition and growth. We were worried about the muscle. The child is not gaining weight because the child's muscle is not developing. That is what we always think. But again, nutrition plays a crucial role because they will have swallowing difficulties. They will have reflux disorders unless we do something about it, like gastrostomy tube placing. This will not improve. The child will not gain nutrition, and enough nutrition will not be supplied to the muscles. So again, putting a tube into the stomach is something families are very much worried about. And taking that decision is a big decision. We need a collective opinion, and we need to get a gastroenterologist opinion, maybe swallow study, and they have to come to a conclusion. They have to convince the family. So putting a tube again is a big challenge, to put a foot and tell them that this tube is needed. Maybe when we consult, when we take an opinion, there are so many confusions happening. We are unable to come to one particular decision even though we work as a team. Because most of the time doctors are hesitant to do these procedures. But definitely if it is done at a right time, definitely it is going to help the babies. So administration of new treatment options for SMA for a person who is sitting in Coimbatore, you know, most of you would have come to me. It is very, very difficult to access these medications. So I can find some sources. You go talk to these people. One person I refer always to is Dr. Ann. Another thing, government has come up with the Center of Excellence registrations. So we are registering with the hope that we may get some medications in the future. That is the only hope we have. But again, registration in Center of Excellence also has its own challenges. A family who is traveling from a remote village from near Coimbatore or anywhere, it is very difficult for them to go do all the tests required in the Center of Excellence and getting registered. So there I take the help of Cure SMA families to guide these families when they come to Chennai. So they all work together, going registration. So we need so much of support also there. So next thing is regarding anesthesia and emergency care. Whenever it comes to an emergency care, a child who is having respiratory failure, what decision to make at that time is a big challenge. We have to consider the ethics and also the family's choices, because most of the time when there will be a question of whether to put the child into a ventilator or not, it will be very difficult for us to wean off the child from the ventilator. So giving the chance to the child and considering all the health factors and deciding upon whether this child will improve or not is again a big challenge, very difficult for us to do from this place. And managing other organ systems, it is not just related to lungs, nutrition, it's related to bones also. So it is a multidisciplinary approach we have to, and each and every unit we have to coordinate. Over a period, we may develop some experience. Say I'm referring a child to one doctor regularly, that doctor also gains that knowledge about managing this child. And obviously, we will refer to super specialists like Dr. Ann. We will learn what they are doing. We try to copy the same. We try to imitate the same. We try to bring out the same standard of care in our place also. So it is just a learning process we are doing, and we are learning from the better centers who are doing this quality of care, multidisciplinary treatments at their center. Whatever we can do it here. Few things has to be done at only those centers. There the families can visit and do. This is what at present we are doing. Maybe from now on, Dr. Ann will enlighten you regarding multidisciplinary care and SOC, standard of care.
Thank you, Dr. Pradeep. You've made my life easier. I thought I will start off with this saying that it's my 12th year in India, and before that I trained in the UK, and at that time when I came in thinking, okay, we can do so many things, exciting things happening, but when you look at I can understand Dr. Pradeep's frustration, because there are so many new things, but to translate it into reality in our setting, what does it take? So how do you form networks to make sure that standards of care are translated to the ground reality, and how to access? He said his difficulty. I have my difficulty. All of us have difficulties. And I'm sure even in countries where 100% coverage is there, even there is difficulty of what amount of budget. These difficulties are going to exist. How do we do this and how do we take it forward? So this is readily available in the internet, 2018 guidelines. This is the world over. This is what is followed. So now I'm going to, this is what I learned. Type 0, 1A, 1B, 1C, 2, 3A, 3B, 3, 4. We don't need to go to the details of it. But I'll tell you what struck me. What struck me was this. SMA2, variable life expectancy. 3, normal. 3A, 3B, normal. 4, normal. How many 2s have you seen dead? Quite a lot, no? Enough 2s dead and 3s dead. So these are preventable deaths. So for me, I was taught this, whatever he's told. I had the privilege of training in one of the oldest children's hospitals in the world, where we had 72 members of staff in the Pediatric Neuromuscular department. So this was all there. We had like some 15 neuromuscular physiotherapists. And then I landed back home. And I was wondering how, this is what is given in the textbook, this is what that was there, and there's just us. Dr. Pradeep here and me there, what to do, how to match. And all of these children that is dying. Variable, set variable for us. Our children were living long, but our children here are not living. So what to do? So we started an effort. So the effort is, as Dr. Pradeep said, somebody who was during inauguration, he said, no, that he left a full paying job to do something else extra. So same thing for my part. I took up a job as an honorary consultant, which means I was not paid with Baptist, and same with Dr. Vinita. So now she's not associated with Baptist. She's got a full-time job in a hospital, which is bread and butter. But she has taken permission from that hospital to say, once in 3 weeks, you'll have to give me one Saturday off. So for me, instead of a pay hike, I said once a week, you have to give me time off. So that's how Baptist started. 2018, 20th of September 2018 was our inauguration. We still don't have a room or anything. We started off, we said, okay, we'll just trust and start. And that was all the various stakeholders, including parent support organization. Mr. Prasanna Shirol has been very much part of it. And with that very ambitious thing, we said, okay, we shall tackle this 1/6 of the world's population. So we get referrals from all over the country, primarily from South India, so much language disparity, and this is our team. So I can proudly claim, and when she had shorter hair, that's Dr. Vinita here, and this is our pulmonologist, and Dr. Terence as well. I've had the privilege of working with Dr. Terence, and many, so we are claiming each other as the same team, because we have a network of teams now. So the disease modifying therapies, they came in 2019. Before this existed, because this is the foundation on which disease modifying therapy can be given. Without that, DMTs have no meaning. And that is what happened with the child that I showed you the picture of, with the shrunken, shriveled looking adipose tissue. That was given by a government hospital somewhere. The child would have died. So giving it, like giving rocket to somebody who doesn't know the other things, doesn't work. But SMA is not so complicated. It has got very established, defined natural history. So non-specialists can get trained to manage SMA. So Western countries and other places where there is a paucity of specialists, pediatricians take over. Geneticists take over. So that is what we hope we can do. So for your population, you need multiple SMA centers here in Coimbatore. So this we've already covered, so I'm not going to go through it. That's the context. And how we started, 2019, Direct Relief said, we will give Spinraza to India. So they said, let's divide India into north, south, east and west. So they divided India and said, we will give it to government hospitals. So north of India, AIMS, SGPGI Lucknow, east of India, west of India, KEM Mumbai. Question was, south what? So the government Apex Institute, they declined. So we got. So we are the only non-government hospital that got it. In 2 weeks' time, we were given 2 weeks to recruit patients. In 2 weeks' time, 144 applications went from all over India, of which a little over 100 were from our center. And the others were from the other center. We just said we won't say no to anybody. So we had patients from Himachal Pradesh who were refused by AIMS, who came to Bangalore. So we were not big, because everybody is a volunteer, including our pediatric pulmonologist works for a corporate hospital in Manipal. First, there was one volunteer doctor. Now there are 4 pediatric pulmonologists to service our hospital, because we have more than 700 children on BiPAP. So it's been collaborative networks. So this is one of our children. So she was diagnosed before we were giving DMTs. Type 2, this is with the firm belief that we can manage these children. She had 6 to 8 admissions. Only child of the parents. Father was about to give up. Mother was very dedicated. And so I saw her in ICU when she was in respiratory failure. So I convinced them, coaxed and cajoled them and said, let's do BiPAP. They somehow agreed. After that, reduced LRTIs, somehow managed to get them to agree to fundoplication and gastrostomy. She was LRTI free for over a year. And after that, she was one of the fortunate children who got selected for Spinraza. She became stronger, everything was fine, but RSV bronchiolitis at age 7. And she was that winter, she was again admitted to the children's hospital. 1 week she was admitted, got better, recovered, and then she got discharged. But on the day of discharge, she came to our OPD, to our ER, collapsed, improved and discharged. So it was not acute infection. It is just inability to create secretions, clear secretions. So in Western countries, every child who's so weak is given a cough assist. It's a mechanical insufflator, exsufflator. It is, in Indian context, is around 4.75 lakhs. Anybody that doesn't have a head control Everybody is given 4.75 lakhs cough assist. We don't have it. And I remember feeling very powerless about it. We somehow managed to get a cough assist on trial. So she was the very first patient in our hospital that we use cough assist. Do you have cough assist available anywhere here? I know that one of our patients has. But other than that, any hospital has access to cough assist, Dr. Terence? So next time when you invite me to Coimbatore, I hope to hear the news that you have. So 7 years ago, 4 years ago, we managed to get the cough assist in our hospital. So we are the only hospital in Bangalore that has the cough assist. There are more richer hospitals, they don't have the cough assist. But we also have a unique system in Bangalore. There are 4 machines on rental. So when the winter season hits, everybody needs cough assist. So that's not, since we can't, this is Indian Jugaad. Since we can't afford cough assist for individual patients, we've just kept a pool, families rent it out. That means you stay out of ICU, you stay out of ventilators. So this girl, when she presented to our hospital being very busy, we had no ventilators free. So we got the cough assist. Every hour she was cough assisted and nebulized. 12 hours down the line, she was sitting up in bed and discharged from ICU. 2 days later, she was discharged home. And so that was her. So huge difference. So I won't go through this. This has already been covered. The next thing that needs covering is preventing fractures. They are not like other children. We need to proactively, not reactively treat them. If they have fractures, we need to make sure that the fractures are treated differently. We need to prevent fractures. Scoliosis often is a result of wedge fractures. So we need to make sure that we are monitoring them serially. This is something as pediatricians we can try and see if we can advocate for presence of DEXA scanning. So he said, what can't be done? But my challenge to Dr. Pradeep, because I know he's got immense energy, is make sure DEXA is available in Coimbatore. It's not so expensive. It's only 3,000, 4,000 rupees. It's just a matter of getting some centiles and softwares, if enough of you, any non-ambulant child that pediatrician is treating, all of them require zolidronate. So if enough of us refer patients, then one center will say, okay, we'll do DEXA scan, and the DEXA is going to be busy all the time. Then that means that you don't have to come to Bangalore for a DEXA. This is not such high-end technology. So these are some of the serially monitored DEXAs where we start giving zolidronate. We give zolidronate after a certain age. Now we are realizing scratch. Patients are becoming bigger. They're becoming bigger problems and they're older and we don't know what to do. So then we start thinking about what is their endocrine levels based on take the endocrine help for do they need testosterone growth hormone or something else, or older children, do they need, our adult colleagues will tell them, do they need teriparatide? They're becoming older enough to need teriparatide or denosumab. So I can proudly say one child I saw recently was just absolutely amazing from Kerala, been following up for a long time. I can't remember the name of the child. Type 2 can move only a little bit his hands. 10 degree scoliosis at 3 years of age, 10 degree scoliosis at 13 years of age, type 2 SMA. They really need to be given an award. So between all of us together, we are making sure that scoliosis did not get worse, and we're giving him Zegra. He came for his 5th dose of zolidronate. 13 years, just 10 degrees scoliosis. So that's the kind of thing that we want to do. DMD, we make sure that nobody gets scoliosis. These are the things that Western countries have. But everybody is running behind only the standard of care. But even after that, there are lots of other problems. So this is when you come in bad shape, this is what we have. We have no other choice. And then we have to stabilize and make sure there is pre-op and post-op. So these are our numbers. But most importantly is the children on BiPAP. These are the children who are living longer. So turning our burdens into strengths. This is our problem. Only small amount is seen because it is good to see so many parents here in front of us. But I'm sure you're the ones who have the courage to come here. So many would be remaining behind in villages, like you said, cannot even go to a center of excellence. You need other parents' support to go till there. But this is the way, this is how we are transforming society. This is how we are building our country. So I don't think this is an SMA problem. This is an India problem. And treating and curing SMA will help other rare diseases, will help building infrastructure for the whole country. So we have lots of SMA. We think there is projected 2.5 lakhs, but the registry, national registry has got only 10,000. We are lagging behind. There are so many obstacles, but we need to, there's positive experts, but we need to multiply. We need to magnify. There's delayed diagnosis, especially for the 2s, type 3s and type 4s. Many of them have no diagnosis. So I'm going to quote Gandhi here saying, our ability to reach unity in diversity will be the beauty and the test of our civilization. And we have diverse and complex problems. So this is one of the things that we feel. Somebody asked me about a mega OPD. We have done mega OPDs. Now we've done 16 so far. The 15th was in Chennai for DMD. We've done SMA and DMD. So what we found was this helps capacity building in a low middle income country. So parent advocacy groups, we collaborate with parent support advocacy groups and do this. If you're doing it for SMA alone, so what happens is you as parents have a certain expectation. We as doctors have a certain expectation. Both are different points of views. Together we can make a difference. So everybody gets seen together. History is taken, they're registry ready-made. You get to see multiple specialists. The last was held in Baptist where Dr. Vinitha was there as well. And they get to see multiple specialists and a ready-made set of parent group is formed. They're bonding over that experience. And there's audiovisuals and doctors and healthcare physicians, healthcare providers talking about these things. And investigations are follow all that. This is cheaper, easy to not only provide care, but as a doctor, I am getting too old to do these camps. I will come for a camp, what we've said is, only if there's another doctor who will say, I will take responsibility. And that person then leads it. So which is what we have done. So encourages and also helps train other professionals. So we've done it in 3 states so far. We hope to do it in Kashmir or somewhere far off. So other thing is training, online training and sessions. So that is it from my side. It needs knowledge of standard of care is completely crucial, not only for parents, but as professionals and policy makers as well. Thank you.